Hello everyone, welcome. My name is Rahul Srivastav from A4Medicine. In this video, we're looking at acute sore throat in primary care. The aim is not just to memorize a prescribing pathway, but to build a fast, safe clinical framework that you can use in real consultations. Sore throat is common and often self limiting, but the real clinical skill is knowing when it is likely viral, when antibiotics may be justified, and when you must stop and think about airway risk, sepsis, or deep neck infection. This video is part of the new A4 Medicine Minor Illnesses series book that you can see on the screen. The aim is to create a practical go to videos for frontline clinicians with the minor illnesses in primary care book forming the foundation for the whole series. The first principle is this: most sore throats are viral, not bacterial. That immediately shifts our default mindset away from routine antibiotics and towards structured risk assessment. If around 70 to 90% of acute sore throats are viral, then overprescribing often happens when we treat uncertainty as bacterial infection rather than working through the probability properly. Group A Streptococcus, often shortened to gas, is the main bacterial cause we're trying to identify. This is the classic strep throat organism. We should also remember Fusobacterium necrophorum, particularly in adolescents and young adults. This is a less common bacterium, but it matters because it can really lead to Lamierre's syndrome, a serious infection involving the throat, neck veins, and systemic illness. But the core message remains: bacterial disease is the minority diagnosis, not the starting assumption. The diagnostic challenge is where the clinicians can often get caught out. The problem is not that we don't know the classic viral and bacterial features. The problem is that real patients often sit in the overlap zone. Cough, coryza, meaning a runny nose or congested nose, conjunctivitis, hoarseness, and gradual onset all push us towards a viral illness. Sudden onset, fever, tender anterior cervical lymph nodes, meaning tender glands at the front of the neck, and complete absence of cough make streptococcal infection more plausible. But sore throat, red tonsils, fever, and even tonsillar exudate are not specific enough on their own. So the principle is do not overinterpret one sign in isolation. Look at the whole picture, then formalize that risk using FeverPAIN or Centor. Before you score anything, rule out the dangerous diagnosis. This is the most important sequencing point in sore throat assessment. If the patient has trismus, which is difficulty opening the mouth, a muffled hot potato voice, drooling, stridor, severe unilateral swelling, neck stiffness, or signs of systemic collapse, you are no longer in routine sore throat consultation. You are in an escalation pathway. Quinsy, also called peritonsillar abscess, is a collection of pus beside the tonsil. It can cause one-sided sore throat pain, trismus, uvular deviation, and a muffled voice. Epiglottitis is a swelling around the epiglottis and can become an airway emergency. Drooling, stridor, tripod positioning, or respiratory distress should trigger urgent hospital assessment. The cognitive trap is using a center or fever pain score in someone who actually has quinsy, epiglottitis, deep neck space infection, Lamierre syndrome, or sepsis. Red flags come first because they change the whole consultation. Once serious pathology is excluded, scoring gives us structure to uncertainty. It helps move us from a vague impression to a more defensible risk estimate. The Centor score looks at four features: tonsillar exudate, tender anterior cervical lymph nodes, fever, and absence of cough. The fever pain score includes fever, purulence or pus on the tonsils, rapid attendance within 3 days, inflamed tonsils, and no cough or coryza. Fever pain often fits UK primary care particularly well because it was designed to support antibiotic decisions in sore throat presentations. But the key teaching point is not to worship the score. These scores do not diagnose strep throat with certainty. They estimate likelihood and help decide whether not antibiotics or a backup prescription, testing, or immediate antibiotics are reasonable. This slide shows the practical nice prescribing logic. Low risk patients should usually not receive antibiotics because the chance of meaningful bacterial benefit is low and the harms of unnecessary prescribing remains real. For moderate risk patients, a delayed or backup prescription can be useful. This means giving a prescription to use only if symptoms fail to improve or worsen after a defined period. This supports antimicrobial stewardship while still giving the patient a clear plan. High risk patients may justify immediate or backup antibiotics, especially if symptoms are significant and the score is high. But even here, judgment matters. If the patient is systemically very unwell, at high risk of complications, immunocompromised, or showing signs of serious illness, this is no longer routine community management. That patient needs urgent escalation. One of the most helpful clinical message is this: symptom control is not doing nothing. In low risk sore throat, good care means explaining the natural history clearly, offering effective analgesia, and giving explicit safety netting. Antibiotics make little difference to symptom duration in most uncomplicated sore throats. So the consultation should focus on pain relief, hydration, rest, advising what change should trigger review. Paracetamol or ibuprofen can be useful when appropriate, when and where appropriate. Adults may get some short-term relief from medicated lozenges. Safety netting is essential. Advise patients to seek help if symptoms worsen rapidly, if they become very unwell, if swallowing or breathing becomes difficult, or if symptoms do not improve after about 1 week. If we explain the reasoning clearly, patients are much more likely to understand that no antibiotics is active evidence based care, not dismissal. Testing is useful only when it changes management. That is the key principle. In low risk patients, testing usually adds little and can medicalize an illness that is best managed supportively. In high risk patients, RADT or rapid antigen detection test can be useful. This is a quick throat swab test looking for group A Streptococcus. It gives a result in minutes and is highly specific, meaning a positive result is usually reliable. However, sensitivity is not perfect, so a negative result does not always fully exclude strep infection when the clinical suspicion is high. A throat culture is more sensitive and is often considered the reference standard, but result takes longer. Also remember EBV or Epstein-Barr virus. This causes infectious mononucleosis, also called as glandular fever. Think about it in teenagers and young adults with marked fatigue, swollen glands, tonsillar enlargement, or prolonged symptoms. So, testing principle is simple: test when the result will change what you do next. When antibiotics are indicated, prescribe with precision rather than habit. Choice, dose, and duration all matter. Phenoxymethyl penicillin, often called penicillin V, remains the first line antibiotic for suspected streptococcal sore throat. For patients who cannot take penicillin, clarithromycin may be used if they are not pregnant. In pregnancy with penicillin allergy, erythromycin is generally preferred if an antibiotic is needed. But this slide also reminds us of something important. Even when antibiotics are used appropriately, they do not dramatically transform the illness for most patients. Most sore throats still resolve within about a week. That is why expectation setting, analgesia, hydration, and safety netting need to sit alongside prescribing, not after it. This slide pulls the whole consultation into one mental model. Start with the history, onset, duration, fever, cough, coryza, contacts, swallowing difficulty, systemic symptoms, and risk factors. Then examine the tonsils, cervical lymph nodes, vital signs, hydration, rash, voice, neck movement, and any airway concerns. Next, actively look for red flags. Only after that, apply fever pain or center to stratify risk. Then decide whether testing will change management, whether antibiotics are needed, and what safety netting advice for the patient must leave with. That sequence keeps the sore throat management safe and efficient. It prevents undertreatment of serious disease and overtreatment of self-limiting illness. If you remember one thing, let it be this: the most sore throats are viral and self-limiting, but every assessment must deliberately exclude the small number that are dangerous or are more likely to benefit from targeted treatment. This reference chart is included to support rapid clinical thinking. It is the from our minor illnesses book and on the section of sore throat. It reminds us that the sore throat is not one diagnosis. It may be viral pharyngitis, streptococcal tonsillitis, glandular fever, COVID, reflex allergy, vocal strain, or a more serious condition such as quinsy, epiglottitis, deep neck infection, or malignancy. For nurses, paramedics, pharmacists, and GP clinicians, this kind of visual chart is useful because it helps avoid tunnel vision. Not every sore throat with redness needs antibiotics. Not every recurrent throat symptom is infection. And not every severe sore throat symptom can safely wait. The chart here is to help you widen the different diagnosis while still making a fast, safe decision. This second chart brings the practical decision making together. It combines terminology, differentials, center, fever pain, testing, antibiotic choices, and patient advice. The key message is that scores guide probability, not certainty. Testing can support decisions but should not be used indiscriminately. Antibiotics are sometimes appropriate, but they are only one part of the sore throat management. For day to day primary care, this type of visual framework helps clinicians make faster, safer, and more consistent decisions, especially in busy clinics, urgent care settings, telephone triage, or same day assessment. This video is part of the new A4 Medicine Minor Illnesses series. The goal is to create concise, dependable videos that clinicians can return to quickly in everyday practice. The Minor Illnesses in Primary Care book will form the foundation for this series. It brings together core minor illnesses topic, evidence based UK guidance, visual decision charts, red flag prompts, prescribing frameworks, and safety netting principles. The book is available on Amazon, and I would very much appreciate if you could have a look and consider buying the book. The sore throat charts shown in the video are examples of the kind of quick reference visuals included in the book. In this series, we'll keep using these charts not just as slides to look at, but as tools to help clinicians think clearly under pressure. The aim is simple: to make this your go to minor illness video series for primary care, urgent care, pharmacy, paramedic practice, and frontline clinical decision making. Thank you for watching. Bye.